Title slide: Rebuilding the Barrier. How GLP-1 engineered probiotics transform the management of fiber-deficient colitis. Dr. Ashutosh Mishra, MBBS, MD, IMS, BHU Fellowship in Diabetes, CMC, Vellore, DMSc, University of South Wales, UK, consultant endocrinologist, Panacea Hospital opening, chairpersons, distinguished colleagues, good morning. Chronic colitis, especially ulcerative colitis, is increasing worldwide, and our standard pharmacologic armamentarium, 5-SA, steroids, biologics, still leaves many patients with relapsing or refractory disease. Today, the focus is on a very specific but increasingly relevant question: can we rebuild the damaged gut barrier in fibro-deficient colitis using GLP-1 engineered probiotics? 1. Fiber deficiency and the collapsing barrier. Dietary fiber is often dismissed as roughage, but physiologically it is a primary fuel for the gut microbiota to generate short-chain fatty acids, acetate, propionate, and butyrate. When fiber is removed from the diet, SCF-producing commensals decline, mucus-degrading bacteria expand, and within days the colonic mucus barrier thins, allowing luminal antigens and pathogens direct access to the epithelium. Animal models of fiber deprivation show exactly this: a thinner mucus layer, enhanced epithelial access, exaggerated inflammatory responses, and more severe colitis when a trigger like DSS is introduced. Clinically, low fiber intake correlates with worse disease activity and more frequent relapses in ulcerative colitis, underlining that this is not just a bench observation, it is a bedside reality too. The fiber SCFA GLP-1 axis. Our short-chain fatty acids do more than provided energy. They signal through receptors like GPR43 on intestinal cells to stimulate GLP-1 secretion. GLP-1, classically an incretin for glucose homeostasis, is increasingly recognized as an important gut immunomodulator and barrier protective hormone. GLP-1 enhances tight junction proteins such as ZO1 and occludin, improves epithelial integrity, and dampens pro-inflammatory cytokines like TNF, IL-1, and IL-6 via inhibition of FNUB and MAPK signaling pathways. In fibro-deficient states, this SCFA GPR43 GLP-1 axis is blunted, removing a crucial endogenous anti-inflammatory and barrier repair pathway and making the cone more vulnerable to colitis. 3. GLP-1 signaling in colitis. Mechanistic insight: in experimental colitis, blocking the GLP-1 receptor worsens mucosal damage, while GLP-1 receptor agonism restores barrier integrity, shortens disease duration, and improves overall colitis scores. Mechanistically, GLP-1 signaling suppresses AKT, NF-EUB, and MAPK activation, reduces neutrophil recruitment, and improves cryptarch architecture, essentially translating hormonal signaling into structural healing of the mucosa. Importantly, GLP-1 is secreted locally in the gut and acts locally as well. So the concept that targeted intraluminal GLP-1 delivery could rebuild the barrier in fiber-deficient colitis is not speculative, it is mechanistically grounded. 4. Synthetic biology and engineered probiotics. This is where synthetic biology enters the story. Engineered probiotics are live bacteria, often lactobacillus or E. coli Neisel 1917, modified to produce specific therapeutic molecules such as GLP-1 directly within the gut. These organisms are designed to survive gastric transit, colonize the colon, and release GLP-1 in situ, independent of the patient's fiber intake. Because the delivery is local, systemic exposure and off-target effects can be minimized, which is a major advantage in chronic inflammatory diseases where patients already carry a heavy drug burden. Beyond GLP-1, the same platform can be programmed to co-secrete IL-10, L-35, trefoil factors, or antioxidant peptides, creating multiplexed strains that tackle inflammation, oxidative stress, and epithelial repair in parallel. ESAST 5. Preclinical evidence. What the models show? In fibrodeficiency exacerbated DSS colitis models, a GLP-1 engineered probiotic restored colon length, improved crypt architecture, and reduced neutrophil infiltration and myeloperoxidase activity, classic markers of mucosal healing. These mice exhibited less weight loss, improved stool consistency, and reduced rectal bleeding, indicating not just histologic but also clinical amelioration of colitis. At the molecular level, GLP-1 production from the engineered strain inhibited AKT, NF-UB, and MAPK signaling, lowered pro-inflammatory mediators, and partly normalized dysbiotic microbial communities depleted by chronic fiber deficiency. Similar strategies using engineered strains to deliver IL-10 have also shown reduced colitis severity, and improved epithelial repair, underscoring the versatility of this living drug platform. The 6. From bench to bedside, key translational steps. To move these strains into clinical practice, safety is the first gate. Non-toxigenicity, absence of transferable antibiotic resistance, and genetic stability to avoid horizontal gene transfer are non-negotiable. Manufacturing must follow rigorous GMP standards to ensure consistent dosing, viability, and functional expression of the engineered constructs. Phase 1 trials will focus on safety and immunogenicity in carefully selected patients with relapsing or refractory colitis, often on background standard therapy. Subsequent Phase 2 and 3 trials will compare efficacy versus existing standards, 5-ASA, steroids, biologics, and incorporate endpoints like endoscopic healing, fecal calprotectin, CRP, and microbiome signatures. 7. Patient selection, monitoring, and ethics. Early clinical use will likely focus on patients with recurrent flares, partial response to current therapy, and documented low fiber intake or persistent dysbiosis. Monitoring will extend beyond symptom scores to include biomarkers, colonoscopic assessment, and longitudinal microbiome profiling to understand who benefits and for how long. Ethically, the use of genetically modified live organisms raises understandable concerns. Transparent informed consent, clear communication about risks and benefits, and robust long-term registries will be essential to build confidence among patients and physicians. Lesson 8. Future directions, sense and respond and personalization. The field is now moving towards sense and respond probiotics, strains that detect inflammatory cues such as specific cytokine profiles or reactive oxygen species, and only then release GLP1 or other therapeutic payloads. This on-demand delivery could further improve safety and efficacy, reducing unnecessary exposure during remission and intensifying therapy during flares. Personalization is another frontier, matching engineered strains to an individual's microbial ecology and genetic risk profile with the aim of not only inducing remission but preventing disease onset in high-risk preclinical stages. Closing to conclude, GLP-1 engineered probiotics represent a scientifically robust, biologically rational, and clinically promising strategy to rebuild the intestinal barrier in fiber-deficient colitis. They bring together diet, microbiota, and immune regulation into a single living therapeutic platform that has the potential to shift us from generalized immunosuppression to precision microbiome-centric care. Thank you for your attention. I look forward to the discussion and to exploring how together we can help bring these therapies from concept to clinic.